Good afternoon, everyone. I hope you all had a great lunch. I'm incredibly excited about introducing our speaker this afternoon, Miss Ophelia Dahl, because of her dedication to public service and for the way she's inspired me personally. Ophelia Dahl's path to Executive Director of Partners in Health starts from humble beginnings. Ms. Dahl completed a degree from Wellesley College as a Davis Scholar in 1995. Before starting at Wellesley, Ms. Dahl's achievements were already widespread. At the age of 18 in 1983, Ms. Dahl traveled to Haiti to volunteer at iCare Haiti. It was there that she met Paul Farmer and within 4 years created the Boston-based nonprofit organization Partners in Health. It was under Ophelia Dahl's leadership that this organization held the widely successful response to the earthquake in Haiti 2 years ago. Ms. Dahl has traveled to and supported the establishment of major PIH products in Peru, Mexico, Guatemala, Russia, and the urban United States, Rwanda, Lesotho, and Malawi. Today, PIH operates over 60 hospitals and health centers in these countries, with a staff of 128 in Boston and more than 12,000 colleagues worldwide. Today, the effectiveness of PIH's community-based model has been lauded around the world, prompting an explosion of requests to this organization to share its expertise and play a greater role in global health advocacy. In 2011, Ms. Dahl was named Bostonian of the Year by the Boston Globe and awarded the SCI Idealist Award by Social Capital, Inc. Along with all of her great accomplishments, Ophelia Dahl's lifelong expertise is that of a listener. Even from a young age, she has paid special attention to listening to people's problems and whatever is on their mind. Ms. Dahl enjoys writing, much like her father, the children's book author Roald Dahl. Ms. Dahl serves on the board of her family's foundation to honor the work of her father. It is Ophelia Dahl's lifelong dedication to service and listening to others that has led to her success in global health. Without further ado, I present the great leader and passionate advocate for the health and rights of the poor, Ophelia Dahl.
Thank you. Thank you, Gina. It's lovely to be here. It always is. I look forward to this talk. This is the third time I've been here to do this. The first time I was due to come and talk, much like today, and actually it was a few days before the January 12th earthquake that happened in Haiti 2 years ago, almost 2 years ago this week. And so it threw me off. We were in a state of absolute flux at Partners in Health. I'll talk a little bit about that here today, but it felt actually as though it was one of the few comforting things that happened that week was actually to come here and feel grounded in this amazing institution that still feels very much like home. Before I start, I just want to introduce two of my colleagues, Amy Heising, who's a Wellesley graduate 2010, and Ben Link, who didn't get into Wellesley. I don't know why, but anyway, as you'll find out, and as I'd like to tell you that a great deal of this work is about who you find to accompany you in this work and the partners that you find, so I feel very lucky to have them here with me today. The other thing I want to say before I begin is that I'm going to probably talk for about 45 minutes or so, and then what I'd love to do is have a dialogue, have a question and answer session. And because I'm going to condense a lot of what we do into 45 minutes, I'm having to pick and choose only certain things. So please feel free as I go along to say, wow, I thought they worked in Russia. Why are they, why wasn't Russia mentioned or something like that? The other thing is that I don't want to assume that you know too much about Partners in Health. So I'm going to take everyone back a little bit, but also sort of happy to go into more details about how I became involved, or indeed, any of the other people that you might know associated with the organization, which has grown a great deal. So I'm very happy to be here. So I sort of just want to talk a little bit, first of all, about what it is that we do at Partners in Health. Partners in Health is an international medical organization that helps to strengthen health systems in other countries where, and really provide access to healthcare where there is none. That's technically what we do. Of course, it ends up being a lot more involved than just that, but that's really the basis of what we do. And one of the ways that we've done this is really to work on this strategy. We have an acronym for everything at Partners in Health. It's so disarming for people who come to work with us because it's like they have to learn an entire language. But we call it the STAR acronym, which is Service, Training, Advocacy, and Research. And it's really what we do is to go in first with service, provide service to patients. But all of those important aspects, training, advocacy, and research, are very important to provide a feedback loop to make sure that you can raise the quality of care in places like that. I think when I started doing this work a long time ago, what feels like a long time ago, I hope it's not that long ago, but a while ago, it felt to me as though the bar was set very low. in international development, very, very low. Simple solutions for what were really very complicated problems, a one-step solution. We still see this even today, and I think it comes out of, without question, the goodness of people's heart, but the idea of simple solutions are very hard, where people are complicated. Healthcare is complicated, and I think that actually some of the solutions are quite complex, but not, as you'll see, even remotely impossible. I wanted to just show a quick slide of a few of the people that we work with. That you can see my great colleague Paul Farmer is up there, but I also wanted to include these pictures of our colleagues in the different countries that almost all of our colleagues are in the countries in which we work. We have a very small, relatively small base. We have about 15,000 colleagues worldwide, and we have about 150 people working at the Boston site. So it includes colleagues in Lesotho and all sorts of other places, including builders and cooks and community health workers and lab techs. And then Jim Kim, who was also an original founder of this, who's now president of Dartmouth, and we stay in touch, of course. But it's really good to see, and really Jim's trajectory, and to some extent Paul Farmer's trajectory, really shows that you don't have to stay connected only to one small organization, but there's all kinds of ways really to do this work. And the other thing is sort of, I wanted to talk not just about what we do, but maybe a little bit about why we do it. The thing that has changed, has not changed about Partners in Health over the years, is that we started off as a group of people who were passionate about healthcare being a human right. And we were, all of us, deeply affected by what we saw in the countries in which we happened to volunteer or go to. We realized that it was because the bar was set so low that it became absolutely sort of something that almost haunted us on a daily level, the idea that people were dying of entirely preventable or treatable diseases, including things like, not a disease, but including things like starvation and hunger, and that sort of thing. So, really that's the thing that hasn't changed. There's a lot that's changed about us over the years, but that really hasn't changed. We feel passionate about that, and everybody, whether they are a builder or a builder of houses or a builder of databases, they feel passionate about very similar things. And I think it's important to know that about what it is that you choose to do. I included this very early. I came across this. This is obviously not a digital. This was scanned in from an old photo that I took many, many years ago when we first met Paul. And the place that they're standing doesn't look anything like that anymore. It's all forested and everything else. But it was really a slide about choosing who you work with. Whatever you do, I'm going to guess that because you're all bright fellows, that you're going to choose something probably demanding to do with your lives. And I can't tell you how important it is to pick people, if you can, to work with partners in this work that will be supportive. It makes a great deal of difference when the work gets very, very difficult. These two chaps here also, they became my close colleagues when I first started volunteering at 18. They took me around the countryside in Haiti, and we did a health census together, and they taught me how to speak Creole, and they actually still work with us. So, and I'm sure, I don't know, I bet you these two young women who are now, I should think, well into their 30s, will still work with us. But it's very important to think about that, and we do often think about that longevity. And also, those were people that are in the community. That's the other thing I wanted to say about this. They, we can talk about this a bit more, but make sure that if you're going anywhere that you go, whatever kind of education you've had here, make sure that you're actually talking and working with people in the community as well. I spend most of my time now in Boston, but I am always thinking about the voices of those people living in the communities, now broader and broader communities of where it is that we work. So early on, again, back to this, with that small cohort to begin with, we did a health census in the area. This is, and unsurprisingly, what came back from the folks that we worked with in that particular village, it was a very poor village of people that we actually have termed water refugees. They became refugees. They lost their lands due to a large hydroelectric development dam, a development project that was, at the time, I think the biggest hydroelectric dam in the Western Hemisphere, built in about 1956 in central Haiti. funded by USAID and all of that sort of thing. And I think actually, interestingly, or interesting to me, by Halliburton, a subsidiary of Halliburton, sort of Brown and Root, I think the name of the company was. But it's still, I just went there last week and I stood on top of that dam, and of course there's all kinds of problems with it and silting, but it provides electricity to Port-au-Prince. But I still stand on that dam and I look out at this beautiful site, which looks like a lake and mountains and all sorts of things, and it's very easy to be able to say, it would be easy to say, God, how beautiful this is, but all I think about is the misery that was created for all of these people who were subsistence farmers, families living there, who kind of raced up into what you can see is it's a stony hillside that they were forced to relocate to. So this was the first clinic that we built. So the answer from that health census, we went around to people's houses. For a summer, that's what I did, working with those two fellows. We walked around to house, and which were long stretches in between. This was a very rural area. And they all said that they needed access to healthcare. They had none, zero access. And so we said, well, hey, we can certainly improve on that. So I went back initially to London and tried to raise a bit of money. We're talking a few £100 here and there. And Paul stayed there for a bit longer, and then he went to medical school here. And we joined up and found some money, and a couple of people in Boston, very wonderful people, Tom White included, started to help us fund to build this clinic. So what happens when you build a clinic and you lift the barriers to healthcare? People come from miles around because they're really sick. And we saw, this is probably a month after it opened or less, but this became thousands of people a day, literally thousands of people. And we realized that although it was a pretty good first effort, it was really inadequate, to tell you the truth, for a couple of reasons which I'd be happy to get into. But one of the reasons is that you start bringing people in and you provide comprehensive care. So you realize you have to have diagnostics and labs and all kinds of things like that, because people who are living in poverty are not going to come with, I got an earache only. I mean, there's very complex medical conditions that are there the same as they are here, only these are exacerbated by the conditions that they live in. And the other thing that happened, very importantly for me as I listened in, because really it was my first sort of lesson in public health, is that they arrived and some of the time they'd come into the consulting room and they'd say, what ails you? And they'd say, I don't have any food, or my roof is leaking, or my children don't have access to school, we can't afford it, or we're starving, or any of these kinds of things would happen. And we thought, gosh, we better think about health a bit more broadly than that which we see only, on a prescription pad. You better be able to know how to build houses or partner with organizations that know how to build houses, or at least think about these problems not just as one disease or only as a healthcare piece. So when in the health census, one of the first things we found out was that about a huge percentage of people under the age of 5 were dying of diarrheal disease. And, ironically, these are water refugees, and I actually walked this last week. I've not done it for years and years, but I walked it to go and see the original pump. But it's a 1,000-foot walk down a mountainside and a hillside, and to the bottom to water. So people will go down, get their water, come back up, and obviously leave them in the gourds and things that they'd collected the water in. And so people are getting very sick. So access to clean water is something that you can do something about. Bigger scale we need to do, this is I'm going to jump to later on to cholera in Haiti, but providing people with access to clean water, we partnered up with a team of engineers based in South Carolina, and they came down, and actually the reason I went to see that pump is it's the same pump that that they put in decades ago that actually pushes the water up the hillside, and we have about 5 standpipes in this village. But really it started us on the road. The importance of this is that we realized just how important access to water is. So you have to give all of these different pieces at the same time. Same thing with housing. If this is what your patients are coming in with, wherever they are, if this is where they're living, and you provide them with antibiotics, maybe even access to water, they're going to stay sick if they're living in this, whether it's the rainy season or not. Wonderful Haitian expression, so many Haitian proverbs and expressions, but this one basically translated says, it's like washing your hands and drying them in the dirt. And that's what some of these sort of early lessons that we learned were about. If you don't also help to find and really improve on these psychosocial conditions, having a clinic some miles away will be only help with a small fraction of it. So we started a building program, actually pretty much everywhere that we work. we started a building and a housing program. And, you know, I have to say, in the spirit of autocritique, we don't do that very well because we only do it on a small scale. So we're still trying to find a number of partners who can help us in these different areas to be able to make sure that we can offer affordable housing for a number of these people who are living in these truly terrible conditions and still are. So a little bit about the way that we learned how to do it. So you saw that first clinic. It's really, it has since then grown into this rather amazing labyrinthine hospital. There are a couple of things about that. First of all, it is labyrinthine. So we had that little clinic, and then we realized that we needed a lab, so we put a lab there, and then we realized we needed an operating series of operating rooms, so we put those there, and then we needed a maternal health clinic, but it couldn't be upstairs because if we were taking women to have C-sections, then all of these different things started happening, and we just built on and built on and built on and built on. And then as the patients started coming and coming and coming, we said, if they're all coming here from around the country, what clinics do they have available to them? What are the public health clinics like? And we had this sort of moment of clarity when we went round to these public health clinics with our Haitian colleagues. All the time we were, by the way, training and working with Haitian colleagues and building up capacity there and training and all of that sort of thing. And they took us around and we saw these public health clinics that were really in terrible condition. They were dilapidated, underfunded, understocked, and the nurses that were often there and the doctors were undertrained. So it didn't surprise us. And there were fees for service. I'm talking 75 cents, a buck, 50 cents, whatever it is, these are all barriers to healthcare. Another barrier could be actually getting to the clinic if you feel really sick. So this is one of the things that we realized is that actually having a separate charity system of building parallel clinics and a parallel system is not something that's really going to help in the long run. It would certainly help with that problem. We don't regret it, but really if we're thinking about changing systems for the long run, then making sure that we team up with the public health sector, however disabled that is, that would be the best thing to try to make more robust that actual system. So we realized that from doing the health center census, that people needed their care in the community, many of them, that to put the burden on them as they were sick or poor to come into a hospital or a clinic, it's an awful lot. You know, especially, it's hard enough sometimes to get to your doctor when you feel really bad, but if you have HIV and TB or if you have cancer, getting to the hospital is very, very difficult. So we realized, I mean, the way that it actually happened, and it's probably worth me going into for 1 minute, is that Paul, who was doing his infectious disease, this is a few years into our work there, he noticed that even removing some of these barriers to access, so providing some of his patients with tuberculosis medicine. It was free, it was available at the clinic, and there were no fees. And he had these patients, he realized some of them weren't coming back. And he thought, wow, you know, this is, in many ways, this is often sort of termed, you will hear it in your lives if you go into this field, as non-compliance. And it's really actually what he realized was when he divided these patients up into two cohorts with exactly the same access, except that for one group, he offered them some fees for transport, donkey rides or whatever, and a supplement for some food and milk. And of course, the cohort that he gave that to, I say of course, it wasn't obvious to us at the time, but that cohort, it was just 100% compliance. So a number of the times it's actually removing this, and that's when he realized that, you know, making sure that we had community health workers, or accompagnateurs, as we call them, Partners in Health. Certainly it's not something Partners in Health invented, the idea of community health workers, but really sort of making sure that we backed that particular horse would be very important. So we started training a lot of people from within the community to provide care in people's homes. Not complicated care, but the kind of care for any sort of chronic disease. And, you know, these days that can be anything from diabetes to cancer care, mental health issues, and certainly ongoing diseases that need ongoing treatment, rather, like HIV and TB. A lot of that we do just in people's homes. But when you have that, they have to feed into a health center. Very important that they feed in a health center, which is really what that first slide of the hospital shows you. It really was a health center. It's a hospital now because we've built and built and built, and it has you know, things that a health center wouldn't. Normally a health center doesn't have ORs and complex labs and that sort of thing. And then that health centre should feed into a district health, or a series of health centres should feed into a district hospital. We sometimes think about it as a sort of hub and spoke. So with the hub as the district hospital, and then the spokes going out into the community. That is, those are the things that really have allowed us to do that. And at the backbone of this, and I include these couple of pictures, is showing that some community health workers. These are going into people's homes and helping them with a number of things. When we started off, we called them agents santé, which is health agents in Creole. And after training them for a while, these amazing people came back to us and said, could we actually rename ourselves? We'd like to call ourselves accompagnateurs. And we said, so tell us why. And they said, because health agents is so clinical. It sounds like we just hand someone a pill. And actually, we feel like we are accompanying them through thick and thin. We are sitting down and listening to them when they talk about what's wrong. We're actually triaging and looking for other issues in the home. You can see these are pretty crummy homes to live in. And we feel like we accompany them. And then one of them said, and they accompany us in some important ways. So it was very important, and it didn't surprise me, having been into people's homes, to know that actually that's what happens. It's not a simple handing out of the pill in a 2-minute thing. And often they spend a lot of time with their patients, talking them through taking the meds and the side effects and everything else. And the important part of it, another important part of this, it's why it shouldn't be a voluntary position. These people are working like crazy and having to make choices between, planting a garden or taking, going to market and that sort of thing. Or this should be a full-time job, because this is going to actually lift up the health of a community. And we can have a conversation later about what happens when a community that is sick becomes healthy. I think it's very important. And they also, if they make a living, they can inject the economy as well. So I'll give you an example now of this is a health clinic that we've rebuilt in central Haiti. It's a place called La Colline. It's right in the center there. But the reason I show you this is that most of the health clinics that I've seen in and around in my travels in Africa or Southeast Asia, the clinics that I see are not very wonderful things. They're usually built, again, a very, very low budget. And they don't look very beautiful. And one of the things that we decided at PIH is that, healthcare and really the right to healthcare and feeling lousy, it should be a dignified process. And so, I have to say, adding a garden inside, so the courtyard is open because of infection control and that kind of thing. But Paul, who's an avid gardener, and now some other people who are avid gardeners, always insist on putting a garden in and pulling a rock in, and sometimes doing even a fish pond. And then making sure that there's a shaded place for people to sit while they wait. As you all know, being sick is no fun. And so making it in, these kinds of places should be dignified places to visit, as they are here. I mean, these places, you go into any foyer in Children's Hospital in Boston, and you'll see an awful lot of work goes into the fish tanks and the special things that happen there. And I can tell you that the people who have to trek long distances to come and get their healthcare here notice this kind of thing. So that's the clinic, and then that can feed into a big district hospital. So I've chosen this district hospital, which we just finished in northern Rwanda, finished it last year. It's called Butaro Hospital. It's just really south of Uganda, and on the border there. And it was it was the place of much terribleness, catastrophe, awfulness in Rwanda in 1994. And we were invited to Rwanda after working in Haiti for 20 years or so. And happy to talk about that with any of you who want to bring up the sort of details of how we got to Rwanda versus other places. But this is the kind of hospital that we're looking at for sort of raising quality, that if you build a kind of district hospital that is a teaching hospital, that's the key thing here. It's a teaching hospital that feeds into a medical school in the capital cities or wherever the medical schools will be, and that you have the kind of treatment available that is going to help everything from this is a neonatal center, neonatology center. That it's actually this is not incredible state-of-the-art equipment, but it is for that area, and it shouldn't be simply warming blankets and that kind of thing. It's not that difficult to provide that, and then to provide the accompaniment with the concomitant medical education, and then having other doctors and that sort of thing. And I'm going to go back to this is a young man who, and I'm going to talk a little bit about sort of inflection points, but also challenging assumptions. This is a picture. This is the same guy. This is Joseph Jeune, and this is him 6 months later. He has HIV and TB, and just in case anyone's worried, because these are the kinds of questions we had to talk about later, he's very happy for us to use his photographs and say his name and everything else. This was somebody who was dying, very, very close to death from these twin diseases. And I think that, at the time, challenging conventional wisdom of it being very, very difficult to treat HIV, and having a system in place with community health workers really helped us to do that. There is no question that along the way that you will in your lives and careers come across people who say, no, that can't be done. This is too difficult. You can't possibly treat people with HIV, especially in rural Africa, because call out the problem. You'll hear them. Africans can't tell the time, don't have access to watches. If they only take some of their doses, then it will become resistant, and that's far worse a problem. Instead of actually getting a group of people together who say, actually, we can do something about this, and at the same time, because of the feedback loop, we will also make sure that we're giving that sort of data to change policy and work with drug companies at the same time to reduce prices. It was really, I have to say, talk about advocacy, but it was the HIV activist community in the United States that did it most for folks living in Africa with HIV. A huge, huge amount to really take on these major problems, because after they had done all of their work here, and they sort of said, okay, there's no pediatric HIV here anymore. There's no, and people are not dying of. People are living with HIV now. They've lived with it for 30-something years. Some people. This is a manageable illness that people don't die from anymore, very rarely die from. So they said, how can we help? And we connected up with them and many other groups. Again, I never want to give the impression to any of you that PIH has all the answers or did this by ourselves or anything like that. We're part of a large consortium and many, many, many partnerships. But these are the kinds of effects that we've seen over and over again. And I was going to show you a picture of a young girl in Lesotho who has drug-resistant tuberculosis. A very similar kind of thing, only a few months later. It feels very good, as you can imagine, to work for an organization that can, take these these major problems that people feel are really insoluble and change people's lives. It's more complicated than that, because what you really want to do is change systems. You don't want it to be like 1 or 2 or 3. It's really being able to do this at scale. And those are the kinds of questions that you all, I bet, will wrestle with. And how do you do that? And I think the only way to do that is to get data and do research and say this is how it is, and then become extraordinary advocates for these people to say what it is that we do. So back a little bit to PIH, and I just wanted to show. Actually, a colleague of mine showed me this slide very recently, and it reminded me as we were talking about our budget at Partners in Health for this year. So this, I don't know if you can see this, but this is the year. So that was about 2000 over that way, and this is the budget in millions. But so you can see, actually, we were on a trajectory to sort of grow pretty steadily for a relatively small nonprofit based here in Boston, and we were expanding over different countries. But you can also see there are definitely inflection points here, and I can tell you what they're connected to. This was the first time we actually accepted money from the governments to treat HIV, sort of larger infusions from the Global Fund. And that sort of thing. A little spike also around Tracy Kidder's book, Mountains Beyond Mountains, which of course did the Organization of Partners in Health a great favor in sort of publicizing the story. That's another piece of this. How do you translate what it is that you will do to other people to make it compelling? And then a sort of steady and then more public funding here. This was really, this is not because we grew enormously our database at Partners in Health, which is still funded often by individuals, but really large influxes of public money coming in, multilateral, bilateral funding that came in to support the work that we were doing. And then sort of, more growth as we went to Africa, started working in Rwanda and then Malawi and Lesotho. Again, sort of finding more support, because actually in the case of Rwanda, the Clinton Foundation came in and they provided us with a lot of the funding early on. And then you can see suddenly what happened in 2010, or roughly 2010. It was the earthquake, this massive crisis. And we were able to, we raised a lot of money because I think the extraordinary generosity of particularly the American people. It's very coming from Europe, where there isn't the same tradition about giving and tithing and being generous. But I think I heard the statistic that almost half of all American households donated to the earthquake relief in some way, not all to Partners in Health, sadly, but to a lot of other organizations. No, actually, I'm grateful that that's the case, although that's complicated too. That's very complicated when you've got 1,000, or rather in Haiti, 10,000 NGOs basically running the country, and we can touch back on that. See, there's lots to talk about. We could take any one of these angles and talk for an hour on it. But that's what happened, so it raced up there. So now what we decided to do is that we would, in 3 years, spend all of that earthquake money, because donors, when they give to you in a crisis, they don't want you to hang on to it for 10 years. That's generally the what people have a tendency to do, or organizations have a tendency to say, oh, great, we got some money now, let's hang on to it. But actually, we decided to make a 3-year plan to spend it. And we had sort of initial crisis relief, and then midterm, and then longer term. And some of that longer term is investing in infrastructure and investing in building a hospital, which we're doing, a big teaching hospital, because the main teaching hospital in Port-au-Prince was completely flattened in the earthquake. So, but then what happens after that? You spend the money that you raised because of a catastrophe, you have budget cuts. We're in this very, very, very painful cycle right now of having to pull back because people give in crises. How can you garner that kind of support to try to capture the imaginations of the American public, who are so generous, to say, it's a chronic, these crises are chronic. It's not just because of a tsunami or a massive dry spell that affects everyone's crops, or worse, an earthquake that people saw, actually in front of their eyes. And this, I just include this picture here of this young man. This is or not so young, but really what happened as a result of crisis is that it does bring people in. So one thing that you can do during a crisis is you can make sure that you strengthen partnerships. One of the lessons that I learned early from Paul is that we called ourselves Partners in Health for a reason. It's very, very hard to do any of this work. Well, it's hard enough to just provide healthcare, or rather accompany a government, local or national, to provide healthcare to a community of people. But to then add in housing or bridge building or water or food and that kind of thing, very, very complicated. So find partners to do it. And what we saw around this time was extraordinary collaborations between Haitian and American or Israeli or Swiss. All of these groups came and descended on Port-au-Prince and provided really extraordinary life-saving care. And they tend to come in, most groups around crisis will come in for a short amount of time. There really is sort of tremendous upheaval. And then we were in this position of trying to actually coordinate some of that care between 127 different organizations, surgeons, some of them who come in to provide help to do one thing. The other thing I just mention, whatever it is that you train to do, try to be flexible too, because I think one of the things that I saw this really firsthand, is there were a ton of people down the first few days or first few weeks after the earthquake. You had amazingly trained surgeons, anesthesiologists, radiologists, nurses who came down. And if you're trained to do one thing and you think that that's what you do, and you suddenly can't do it because we couldn't get the generator running, or because something happened, there was no light, people were using their cell phone lights to operate by, and suddenly surgeons can't operate, they'd feel terrible, but they'd then go back to their rooms and do what they could do, read or whatever. And one of my colleagues sort of went back and talked to them and said, a lot of these people are actually dying tonight. They're dying alone in their, on the cots or on the floor or whatever it is. Could you come back, and actually the best possible thing you could do right now would be to be with them while they die. And many of them did it. but it, you know, sometimes we're trained to do one thing and we think, you know, how can we maybe be useful in other ways at different times, particularly in times of crisis? So, and I'm sticking on Haiti, but happy to talk about any of the work we do elsewhere. One of the things that happened as a result of this, which isn't surprising, is that, you know, just to put it in context, so you probably all remember, I sort of live and breathe the earthquake still, and it's just the anniversary. But what happens when, you know, a capital city that has everything in it is decimated? Many, many, many people die. Over 300,000 people died. Probably 25% of the civil servants died at that time. 27 out of 29 of the public buildings, so all of government buildings, crushed. Airport out, everything out. You really have a very difficult situation, and then you have 1 million people homeless. And you have refugee camps coming up overnight. And, you know, other countries that have seen crises from war and that sort of thing are very familiar with this. So you had no way for anybody. I remember in the first few days after the earthquake, one of the other things that, you know, we were in touch with, we were trying to be helpful, not just to obviously to the patients and people in need, but how could we accompany the government at a time like this when they'd lost everything, including their colleagues, the UN. They lost dozens of their people there. One of the things is that there is there's the kind of response that you know, you have to find ways to actually accompany them. And I think that for us, when we were, you know, we talked to different people, and it was the Minister of Communications actually didn't have a cell phone at that time. So making sure that people can be able to do their jobs. And she said, could you bring a cell phone? Could you bring this? Could you bring tents so that we can have an office so that we can start to work? NGOs often don't work that way, or they stay within their sort of confines. That's why I think it's important that we sort of touch on what's known as mission creep. Or not mission creep, but, you know, really to say, how can you be most useful in times of crisis? But one of the things that happened is, you know, well before the earthquake, I think Haiti was 147th out of 147 countries in a water poverty index. And so the fact there was no cholera in Haiti before, you know, a year, it was October 2010, I think. But everybody should have known that it would come with these kinds of pressures, including hundreds of thousands of people leaving the capital city, going out into the countryside, no access to water or municipal water systems, no access to water. You can't bathe and defecate in the same place when that happens, and throw in hundreds of thousands more people. And in many cities that I've been in there, there's no real water system. So, you know, whatever NGO, and we feel terrible. We feel like we should have done more in this respect, but putting water filters in people's homes, sand filters, or digging wells, or doing that kind of water project I showed earlier will help. But, you know, once the cholera bug gets in a water system and everybody's drinking from it, it's really terrible. So it's a huge crisis in Haiti right now. I think it's the biggest epidemic of cholera in the world at the moment. 500,000 people have been sickened with it. But you know, as a crisis, as a medical crisis, we, with other groups, were able to respond by putting up cholera treatment centers. But the interesting thing, I think, for some of you who might be interested in policy and how these wheels churn and that sort of thing, early on we said, my colleague said, you know, there's a vaccine for cholera, perfectly good vaccine that works. And everyone said, you know, so we sort of then got in touch with big organizations that make decisions around vaccines and that kind of thing. They said, yeah, but it hasn't been tested or piloted. Well, a little bit of probing showed that actually it had, and it was efficacious. But, you know, for some people, I work with extremely tenacious people, and for a lot of people would have said, oh, darn, it hasn't been piloted. We better not, we can't. Well, let's leave that well alone, and let's carry on and just provide. But cholera is very treatable. You could die extremely quickly, but you can also get revived very quickly. I went to a cholera treatment center in the center of Haiti just last week, and there was only one person in this huge treatment center, big tent with cholera beds and all that kind of thing. It will be fuller in a month's time when the rainy season starts. But the way that these are by being hydrated, some of them get antibiotics. But there's a vaccine for this terrible disease, and it works. So we have been, you know, trying to get this vaccine released, and it's made by a company in India, and we have about 200,000 doses released. Actually, we're starting, I think, February. And it's an oral vaccine, not very difficult, but if you have community health workers in place, if you have a system working with colleagues in a country, it's really not very difficult for us to do that. We rolled out the HPV vaccine for young women before the earthquake. Actually, the first is 3-dose. That's intramuscular, much more complicated. That, or at least it's an injection, it's not an oral vaccine. And that we had a better completion rate where we work in Haiti than there is in New York at the moment. And that was before and after the earthquake. That is because of community-based care and being able to sort of reach out and cover the bases. The same thing with the cholera vaccine. It's very frustrating to us that it takes so long to get this stuff going. And I think if we hadn't had the sort of folks that we work with in Haiti, another organization called GESCIO, who pushed on these levers as well to be able to say, you know, what it is that is needed by this community. And when people say to you, as they inevitably will, it can't be done, it's too difficult. I really think find ways. That's why the partners you choose are so important, because when you go back with your head low and say, it can't be done, you can actually say, well, I'm not sure that that's the case. Let's sit down and put our heads together and find ways to do it. I wanted to put this up just to reinforce this partnership piece. You know, we at different times have worked with, certainly with governments, that's the Haitian flag, but all these different groups that can actually provide different things at different times. NGOs particularly have this, they tend to silo themselves, and certainly PH has been guilty of that at different times. We try not to, and that lesson we learned about working with the public sector relatively early on, it was a very important lesson to us. But all kinds of other groups that you can work with to make sure that they're actually bolstering what it is you're doing, and you're bolstering what it is that they're doing. Some of these other groups don't actually work with governments, and that's hard too, but you know, I think one of the hardest things that we do is to partner and accompany governments, but it's also, importantly, one of the best things that we do. And then I sort of just wanted to give a snapshot, and then any of you, we thought we could sort of go into questions to talk about where it is that we are, and how, you know, it looks like, I said to someone, it looks like we took out a map of the world and just threw darts at it and ended up there. There's actually a very connected reason that we're in these different countries. And, you know, started here, working in central Haiti with that small group and built up around it. When we learned those lessons, we then found we were invited to work in Peru. That is where we found, when we were actually going just to do a small, modest $30,000 water project, we found out that actually one of our close colleagues was dying of drug-resistant tuberculosis. And we thought, if Jack is dying of drug-resistant tuberculosis, it must be everywhere. Now, Peru is a middle-income country. It's a very different thing from Haiti. It's why there's drug-resistant tuberculosis and there isn't. Haiti's too poor for drug resistance. So people were being treated empirically, given not a very, not sensitive, that their TB wasn't tested, so that they were getting worse and worse. So we ended up working in Peru very specifically in drug-resistant tuberculosis. We got a big grant to carry on sort of proving that, to try to take it to scale. TB is still killing, I think it's one of the largest infectious adult causes of death in the world today. So how do you do that? I don't think we've done that successfully at all, taken that to scale. And that's really why we ended up working in Russia with actually mostly in the prison sectors with patients who were involved in petty crime, often got into prison and then actually caught drug-resistant tuberculosis and essentially got a death sentence. So we started working there. But the folks here, the community health workers and the trainers who started working with people who had HIV and TB, they were the ones, when we were invited to Rwanda, which is the first place we went in by the Clinton Foundation and the government of Rwanda, it was our colleagues in Haiti who came to Rwanda to lead the training efforts. So although we are connected to the Brigham and Women's Hospital, we're connected to Harvard Medical School, we're trying to make sure that our research and teaching is not simply Americans going there, but that we actually, as we train and teach and that sort of thing, that actually those teachers are then going to other countries to train and teach. One of the things I was doing in Haiti last week was actually attending a family practice residency, which is the first family practice residency that is there. With about 7 of our Haitian colleagues who've just finished medical school, and it was to really to go and celebrate this new residency that was paid for again by partners here. I think it was paid for by I think it was paid for in part by the Clinton Bush fund that happened after the earthquake. So knowing that there are all these kinds of ways, it's not just providing service to the patients, it's also actually making sure that you have a robust research and teaching piece of this as well. And then finally, just to say, just for 2 seconds, that as you go along, you learn a lot. You mustn't be frightened about making mistakes. You will make many mistakes along the way. It's important to work in the kind of environment that really allows you to talk about those mistakes and learn from those mistakes. I got a long list of mistakes that we've made. Hopefully, I think the importance is to sort of learn and not make those mistakes more than once. And then, again, this collaboration piece is very important. Really the other thing is that most of the work that are done in the kinds of countries in which we work by people who are employed by organizations that are based in Geneva or London or New York or indeed Washington, they have a tendency to put people in capital cities. I just want to urge you all, fine to work in capital cities, but if you are in the position of making decisions about people's lives, make sure that you go out and know and get to know the communities whose policies or things that you're trying to do are that you know what this is all about. Don't be tempted to stay. It is very tempting to stay with the people that you speak your language, want to have dinner with every night. I think it was a very important early lesson for me, totally encouraged by Paul, that we actually lived in the community in which we were working. It makes a big difference when you're actually living in a community rather than staying away in sort of meeting rooms. And that's slightly the temptations, and a lot of the decisions are made by people who really don't get out in the community enough. So with that, I just want to say thank you, and very, very happy to answer questions and talk for a little bit now. I think we've got at least another 25 minutes or so, so feel free. But thank you for having me. Before we do that, we've actually got I think it's a 3.5 or 4 minute video that we're going to try and jump. We couldn't stream it with this, but I think we're going to jump onto it. It's really a little bit about accompaniment after the earthquake. It's 3 or 4 minutes, no more. But it's about a very small scale effort that we did. But I thought, for me, when I saw this recently, it reminded me just how important and what kind of sort of hands-on accompaniment is necessary. And then we'll have 20 minutes left to talk. So, good. doing, and if not immediately a question, I'd love to know a little bit about what you're doing. Yes. Could you tell me your name?
Hi, my name is Genia. I'm doing global warming as our topic, and I was wondering if you had, as in your organization, talked about a little bit about changing disease vectors that will accompany climate change. I know there's a lot of uncertainty about where they'll go, but have you guys thought about any adaptive techniques yet?
Could you go into a bit more detail about that?
So, for example, with the warmer weather, there might be changes in malaria, and there might be changes in water supply and clean water access, so that might significantly impact a lot of bacterial infections.
Things that we do, we care a great deal about renewable. I mean, trying to incorporate. We'd love to be sort of carbon neutral in a lot of our sites, so sort of really thinking more about renewable energy rather than climate change itself. You know, I think like any of these important movements that need to be addressed and by different groups, I think climate change, of course, is going to have some terrible effects. Have we actually sat down and really thought about what vectors could change as a result of it? No. To tell you the truth, it's hard enough for us to sort of really get some of this stuff going without thinking about, you know, short time down the road, which isn't to say that there aren't people there who are interested in this or thinking about it. I think it's an extremely important thing to think about. But I do think that getting some of the solutions right now, so if people feel that it's too hard to get medicine to people, you know, in today's climate, I think that we have to sort of work very hard on changing hearts and minds to make people realize that that is, or really allow people to understand that that's something that's very, very important. And then I think some of these important climate change results will be easier to tackle. Although I think they should be tackled before they happen. I think you're right. What group do you know that's working and thinking about this very well and connected to, say, health?
Unfortunately, the reason I'm asking is that there really isn't that much out there currently. Just because it's really hard to predict where exactly a new disease might spread. So it's all pretty much tentative. But what I was thinking about more was kind of a backup plan for relief when there's an outbreak of a disease in a region that hasn't seen it yet, because they might not be prepared to face it. So if there's anything that happens like that in present day, could you expand on that a little bit?
No, I mean, I can't think of anything. I mean, I think that you're the kind of person who's going to come along and help with that. That's why I'm delighted that you're involved in this. You know, that it's you know, thinking about these, having things like, you know, I was just talking about the cholera thing. There are vaccines available. I think a lot of the time we actually have plans and solutions in place. For whatever reasons, humans don't like to change what they do very easily. So they tend to dig their heels in and say, oh, yeah, it's going to be very hard to get the cholera vaccine to Haitians. And what happens if we do this and don't do that? We have to make sure that these vaccines aren't stockpiled for only when we get avian flu. You know, to make sure that these kinds of things move at different paces for different groups of people. So there's a very good, I'm just forgetting the name of the book that Paul recommended to me, which is really about how climate change and health and poverty alleviation and breaking the cycle are all intimately connected. And if we make them different movements, it'll be a great mistake. And so I think you're absolutely right to pull them together. And you know, I would love to hear more about it. Do you see any ways in which the presentation there could sort of, do you see any obvious forays in, for example? Like anything jump out to you in terms of, oh gosh, they're gonna miss that boat if they don't?
I mean, I think a huge part of it, as far as adaptation goes, you guys mentioned providing not just healthcare, but water, food, and shelter, and that's a big part of it with climate change. You need to look at adaptive crops, and you have to look at water security issues, and that, I think, will be a much more prominent issue, especially in Africa, where there are a lot of vulnerable areas.
Yeah, I agree. I mean, I think that, you know, getting some folks to, getting groups to come together to actually partner in this is going to be the key thing to do, because otherwise, you know, if you have a climate change group working absolutely not in concert with other, you know, an agricultural group who are now, right now, sort of working on crops or not working on crops, I think you're 100% right. I think it should be done. I think you should get right on it.
Thank you.
Yes, in the red.
Hi, my name is Kaylee, and I'm in the group that has the task of securing investment for securing financing for infrastructure investment, especially with regards to communications technologies. And I was wondering if, in Partners in Health, you've ever partnered with a telecommunications sector or a mobile provider, an internet provider, to help the public health cause.
Yes, we have in a couple of different ways. We're working with a provider, a cell provider, a big one actually, based in Haiti. Actually based in many countries, based in Ireland actually, I think. It's called Digicel. And that company is a group that's done an awful lot to both sort of lift up the economy, but also look at ways that you can make, have availability to be able to use that for community health workers and that kind of thing. I think that there are all kinds of, I think that a microfinance company that we're working with, an organization called Fonkosi, based in Haiti, is also looking at ways that loans can be done online in Haiti, and certainly there are many companies doing that in Africa. We have a research project going on to do with data collection using PDAs, and make it actually, if you're collecting, we have an electronic medical record that we use for our patients that we're always working on to try and improve. And the data that's collected at the patient homes then up until now really had to be transcribed, and obviously opening doors for errors and all kinds of things. So we have a grant that we've been working on to actually use PDAs to put all of the information in that way and then just have it transported straight to the server. Yep. Yes.
Hi, my name is Bethel, and thank you for coming to speak to us this afternoon. My group is working on education, and I was curious if you reach out to the local schools in the rural areas in these countries and to teach about hygiene and sanitation and things like that. And also, I just wanted to say that you have my dream job. And
come and get it. No, seriously.
I was
really.
hoping you could talk to us about the challenges that you face as a woman and as a professional humanitarian in your job.
Oh, thank you. I actually don't take that lightly at all, that I have your dream job, and didn't mean to sound clear, but that means a lot. And I have to say that it's a difficult job, particularly in budget cut times, and it's complicated. But I think I keep going back to this idea of making sure that you have teams of people that you can grow with, and it really seems like a few years ago, I think it was a few years ago, that we were 20 people at Partners in Health, and that earthquake spike and a couple of other spikes have really pushed us to grow much more quickly. And it won't surprise any of you. It's painful growing. It's very good growing in some respects because you're affecting more people, and you feel as though you're just being more effective as an organization. On the other side, quality can be compromised quite quickly if you grow very rapidly. And also there's something that you lose in not knowing every single person well, or not being able to train and mentor everybody. But that's why it's so important to have concentric rings of circles of people who are training and mentoring and that sort of thing. But I very much hope that you have a job just like this someday. And as we say at Partners in Health, we are constantly looking at making sure that we're entirely replaceable, as everybody in any organization should be. And it sort of goes back to that point about working with the public sector. If an NGO is working, if a community is absolutely reliant on an NGO, then that's just too vulnerable. I think building systems is really the way to go. To education, I can't tell you how important I think that education is in this whole equation. As a healthcare organization, we also spend probably more money than anyone would imagine on education, and we don't do it very well. Meaning, I think we do plenty well in terms of the broad-scale education around hygiene and that sort of thing. But I mean actually building schools, because as I think all of you here know, that education is about the best indicator for health outcomes, and making sure that women. I think I heard I think this is still absolutely true, but even getting a primary school education will reduce your likelihood of HIV prevalence. Primary school education. So even knowing how to read will make you less vulnerable. So education, it's enormously important. And again, finding a partner who could really do a good job accompanying a government to build schools would be the way to do it. What tends to happen in the places I work is that very well-meaning groups come in, as we did when we built our first clinic, and said, oh, we should build a school here. And then someone, oh, we should build a school here. So they're absolutely reliant on, Kansas church groups raising money for that. And then it's very difficult to accompany the public sector of education. So finding a way to help to build and strengthen an education platform would be an absolutely key and really difficult and really key to be able to do that. But in terms of the sort of prevention and education techniques, it's really part of the public health piece that we do. With cholera, we go around and have training sessions obviously on sanitation and that sort of thing. But often it's not the education that's lacking there. I mean, the common sense, it's really literally an access to soap and water, clean water. So making sure that when that your education efforts make a lot of sense. So don't come in and say, you guys should be having more rice and beans and vegetables. That's what has often tend to happen, but rather, I wonder what's preventing these people from having rice and beans and spinach. And sort of, we've tried to do that with our very small-scale agricultural efforts as well. Go over this side. Yes.
Thank you very much. My name is Pratibha, and my group is mobilizing the political will to assist victims of natural disaster. And I was just wondering if you can talk about how do you convince other NGOs and organizations to collaborate with you, and what are some of the incentives for them to collaborate, and also what might be the challenges in bringing together different organizations that might have different agendas, goals, and different time scale to operate?
Getting people to collaborate is much more difficult than you'd think. I mean, it's probably not here in this particular classroom, or I seem to remember a huge amount of collaboration when I was at Wellesley in different ways. But I think that a lot of the time, sometimes people are socialized in different ways for success or failure. But and certainly we're socialized pretty, I would suggest, I'm not going to be presumptuous, but I think pretty much all of us were socialized for success. But the actual ability to come together, it's not, people tend to silo themselves. Or groups tend to silo themselves. So MSF does this, and some other surgical group from Israel. I'm thinking the disasters that I'm most familiar with are massive flooding that's been taking place a couple of years ago in Haiti, and then the earthquake. So really, it was a crazy amount of people all working independently. So to have to pull those people together, I think the best way to do that is you have to sort of really convince people, and people have this in their hearts anyway, that they want to be successful. And so if you have a team of surgeons, but they didn't come down, sadly, with an anesthesiologist, they're out of luck. Or you have a group of agricultural, I mean, sort of, any kinds of that, not so much in disasters, but you really, I think that's part of this work, is being persuasive, finding ways in really very difficult circumstances to persuade people to come together. When you've got one tent that says this group and another tent that says this group and another tent that says this group, and they all feel accountable only to themselves, but really bringing together people to say the outcomes will be much, much better if we team up together and do this. And I think there's no magic formula for any of this stuff really, but it's trying to be persuasive and make sure that people come together and actually then show them what happens when they do come together. I think that's it. There was another part to your question?
I just asked about the challenges
in bringing people together and getting them to collaborate. It's really that people seem to be more. They tend to want, because it's simpler to operate. Just as it's simpler if we could concentrate only on diphtheria or only on malaria, it would be an awful lot easier for what we're doing. But most things do need a holistic response, because you can cure someone of malaria and then they'll break an arm badly, or they'll have a car accident, or they'll get cancer. And if you're only working on one thing, but that's the tendency, because it's a bit simpler It's quite a bit simpler. It's easier to fundraise for, that's for sure. Although I know you were talking specifically about crisis, I think it's exactly the same answer for that. That people tend to want to work apart because dealing with other people and other groups that have different mandates and different rules of engagement, and oh my goodness, and in the public sector as well. I'll give you a small example. Making sure that you can sort of, again, you don't need to reinvent yourself or your organization or the group that you're working with necessarily, but you need to keep being open to recalibrating. Like, what happens if you're set up to do one thing and then there's a tsunami? You can't say, I'm sorry, we only do this. You have to say, oh my goodness, if we're doing this and there's just been a tsunami, we better recalibrate and think about what it is we're doing, at least temporarily. And I think that that's one of the most important things. After the earthquake, again, PIH didn't work in Haiti, we didn't work in Port-au-Prince. After the earthquake, it hit Port-au-Prince. If we are going to be able to spend the money that we're raising and have an effect, we better work in Port-au-Prince for a while. And one of the things that we did when the General Hospital was crushed, the nursing school was collapsed. The whole second-year nursing class, the students died in a few seconds. And so, in asking yourself, how can you help? The Red Cross is raising a great deal of money, and they're worried about spending it quickly because they're worried about being accountable for it because it looks like pandemonium. It is pandemonium. So how can you then, we thought to ourselves, we're not really in the position of doing this normally, but how could we be most helpful? The General Hospital needed to keep Haitian doctors coming to work and keep things much as usual. Could Partners in Health be a conduit there? Because we already are set up to be able to have, we had relationships with, we have accounting and all of that kind of thing. Could we take some of form a partnership with the Red Cross, find out what the General Hospital needed the most, take the money in, account for it, make sure that it was all done properly, and then give it to pay the salaries of the Haitian doctors? It's not really in our mandate, but if we wanted to be able to be most useful and help this kind of thing, those are the kinds of partnerships you need to forge. So I would say partnerships, even unlikely partners, not morally reprehensible partners, but unusual partners that you might not have thought that you would have any connection to. Be open to that. It's been quite hard even at Partners in Health to say, let's try and do it. We have in Lesotho, it's all mountainous. We have to make sure that we can get our patients and doctors to the sites. We work with this wonderful small group called MAF, which is Mission Aviation Fellowship. And they're a group that just flies airplanes. That's all they do. They bring their families out there and they fly airplanes. They have to go back as part of their mission, raise money, and keep those planes flying so that we couldn't do it without them. So I think it's one of the most important things that you could possibly do is finding ways to collaborate. Collaborate, education, global warming, they're all really, really important pieces of this. Yeah. Yes. Gina.
Project of raising the funds to halt the spread of HIV/AIDS, malaria, TB, and cholera. And something that we're looking at is definitely this collaboration between NGOs and the government. And I was also looking at your problem of volatility of funding, and I just wanted to ask about two possible solutions we're looking at in our project. Is for the collaboration of NGOs and the government is probably offering an incentive for governments to contract with NGOs, several NGOs, but obviously not all NGOs are as great as Partners in Health. And have that great rating of using funds and getting it to where it needs to go through great monitoring and evaluation. And I was just wondering, do you think that that's a possible solution of contracting with the government?
Sure. I think governments, I think that the way to do it is through the governments. Most NGOs won't work with governments, particularly if they're weak governments. That's what we've noticed. So, it's a very contrasting situation, Rwanda and Haiti. In Rwanda, you actually have to register with the government. You can't do any work there unless the government sort of helps you they ask you or tell you what they want you to do for them. Otherwise, you get this sort of, there's been some outrageous situations where you have sort of 132 groups just working on HIV in a sort of 3-mile radius with 12 patients on treatment. That's happened before. So making sure that the government is actually in a powerful enough position that they can work with the NGOs, and then having those NGOs work and partner with the government sectors, whether it's on public works, education, or health, or any of those things, security, agriculture, Department of Agriculture, I think it's absolutely the way to go. The difficulty will be persuading the NGOs to do that, because it's not easy, particularly with governments that are, somewhat underfunded by, by all kinds of, by other governments. I mean, you know, you have a situation, Haiti's a long and complicated and tortured, impoverished history, but a very important history for where it is right now. But I think that is an excellent way to go, and I would say the problem won't be so much the government. I think the problem will be the frustration that the NGOs will have working with governments, and that's really the secret to the long-term partnership piece. And when I say partnership, I don't just mean partnerships between NGOs, I mean just that.
Does PIH accept any funds from the governments they work with?
Sure. Oh, we give the funds that we work with
Right.
to the governments.
Funds from the government.
From, you mean the US government? They don't have any funds. We give it the other way around. So, just to give you an example, the Ministry of Health budget, it's about $2 per capita. And Massachusetts, $7,000. So there's no money in that public sector for all kinds of important reasons that you all should look into. But so we get money, so we now raise money in all sorts of different ways. We give it to the Rwandan government. Fully 50% of the work that we do is through, I mean, we in really sort of helping and supporting the clinics and the clinics I was talking about, that comes through the government. So the Ministry of Health. So they then pay their doctors, clinicians. We then top up things and make sure things are working or pay for refurbishment. But what we're really trying to do, and I don't do a particularly good job, I understand, of really explaining this, is we're supporting the governments, local and national. So sometimes it's a district health commissioner in the middle of the countryside, and that usually feeds in, hopefully that feeds into a system that goes right to the government. So we accept money from individuals, from governments, from foundations, and from corporations at Partners in Health. And then we allot that depending on what our strategy is for the 2 or 3 years that we set it out. And then we send the money both to the governments that we're working with, but we have a very close, we don't just say, here you go, see ya. We're absolutely there with them, accompanying them in carrying out the mission that we all agreed to. But we want them to do it. Does that make sense? Are you sure?
Yeah.
Okay, because it's complicated and it's sort of counter to, it's usually that the government, I mean, you know, certainly it would be nice. The Rwandan government, for example, gives money, you know, is I think supporting 50% at this point of operations at Butaro Hospital, something like that, of that lovely big district hospital. They're supporting that. We've helped them get DFID grants from the European, from the UK to be able to help that. So there's all kinds of ways that you can do it. But what we don't want to do is just have an enormous budget so that that they need us to do this. What we're trying to do is really accompany the governments in this. Happy to talk about it more as well. Yes, patient one. And Joanne's here, so I have a feeling that we may need to wrap up soon. But carry on.
Hi, my name is Lena, and I actually wanted to ask you about your work in Russia.
Yeah.
And what it mostly is, because I know in the 1990s it was HIV, AIDS, TB. What other disease trends right now, or like also have Partners in Health done any infrastructure work in Russia?
Yeah, not too much infrastructure work. The nice thing about working in Russia is that they have a robust medical system and everything else. Whatever might be broken, and you would certainly know far more about it than I do. But really the way that we accompany is we've been part of a Global Fund grant, and it's training the trainers. So we did in the early days, 15 years ago, we went there because all of these patients were dying, prisoners were dying in prisons. It goes back to a separate grant, and another couple of groups were working there, and they needed to pull out, and they said, look, we know that PH sort of has long-term ties, provides long-term ties, and so we went in there and we started working with mostly prisoners and, you know, giving them directly observed therapy, making sure that their tuberculosis got better, their drug-resistant tuberculosis got better, and their HIV was treated. So because they didn't need help in if a prisoner broke his arm, they had access to orthopedic surgeons. It's very different than working in rural Rwanda. So that's mostly what we're doing there. So we've been helping them. Some of the time, the actual the grants from the Global Fund and that sort of thing has come through Partners in Health. And actually, we have an office in Moscow that does a lot of that work. And we're working in Kazakhstan as well, doing just the same thing. But it's really technical assistance. really. And then we have great doctors from the Brigham and from Boston who train the trainers. They go out there on these great jaunts and have these long training sessions, and they talk with pulmonologists and people who are treating this disease very, very well.